Hello, welcome again to Miami Community Health. I'm Dr. Anthony Gonzalez, and I'm your host for another important health topic show. You know, September is opioid awareness. There's a day in September that we really look and try to bring awareness to our community about opioids. So the question is, what is opioids? Well, opioids obviously are a medication. It's a drug. We're going to talk today about opioids, and we're going to talk about opioid epidemic. You've heard about the opioid epidemic in our country. And so we're going to talk about opioids. We're going to talk about the opioid epidemic. But to be able to talk about opioids, we need to bring a particular type of doctor, and that is a pharmacist. A pharmacist is a doctor of pharmacy that deals with all these medications. So I brought our pharmacist, our lead pharmacist, our assistant vice president of pharmacy at Baptist Hospital, Esty. Esty, welcome. Esty Trimino here with us.
Thank you, Dr. Gonzalez.
All right, Esty. So first, let's start off with pharmacy. What is a pharmacist? What does a pharmacist do?
Oh, wow. We do many things. As a pharmacist, we are the medication management experts. So we know a lot about medications and how we treat diseases with medications. We look at therapeutic interactions or how the medications interact with our bodies. We're able to look at adverse effects, drug interactions, and anything related to the medication management of the patient.
Now, obviously, as you guys are learning the medications, you guys also learn about all the conditions that these medications treat, because we as physicians, we're a little different. We learn first about the medical conditions and then the treatments.
Yeah, we learn basically the mechanisms of actions of the medications, where they work and which parts of the bodies, and then we learn the disease states for where these medications would work. And then from there, we look at the optimal drug treatments for those types of conditions for patients. So we're looking at how the medications will interact with various conditions to prevent symptoms for our patients, to help them manage their chronic conditions or acute conditions or anything like that.
All right. So we see pharmacists in a lot of different locations. Obviously, you are mainly at Baptist, obviously, at a hospital setting, but we have pharmacists that work, in pharmacies like our local drugstores. So where are pharmacists and what other areas do we see pharmacists?
So pharmacists are everywhere nowadays. So we definitely are in the acute care settings in hospitals. We are in retail settings, such as, our pharmacies or independent pharmacies. We're in long-term care facilities as well. We work in wellness, anytime with sports medicine and sports medication, anything related to that as well. You'll see us in regulatory in CDC and FDA regulatory areas. We can be in drug companies, pharmaceutical companies, where we act as the pharmaceutical expert for anything related to the medication. Lots of education. So we're also part of universities for teaching different types of classes like pharmacology, working in many different areas. But basically, we're everywhere.
Wow, that's true. And I heard there's like over 300,000 pharmacists in the U.S.
Yes, there is over about 350,000 of us. I think that was the last numbers that we had through the ASHP, or the American Society of Health System Pharmacists, which is kind of our big governing body. But we do have shortages of pharmacists in hospitals today. So even with those numbers, that's one of the struggles that we have today within the pharmacy profession is within the acute care setting or the hospital settings. A lot of pharmacists are going to different types of settings and more ambulatory care settings or to drug companies or things like that. So our hospitals actually have shortages. So we do have shortages of pharmacists and pharmacy technicians within the workforce. So
wow. Okay. Well, hear up, everybody who's interested in pharmacy. Okay. So what type of individual, is a pharmacist? What type of skills do you have to be a pharmacist? Because you may deal with a patient, but like somebody who's working for a drug company may never see a patient. If you're working in regulatory areas, you're not. So what are the skills, or what is the type of individual that loves to be a pharmacist?
Yeah, I think that one of our biggest qualities that as pharmacists we have is really paying attention to details and really looking through the medical literature and the research behind medication. So we're able to share that information, having communication skills that are able to communicate, active listening skills, as well as being able to educate as much as we can. So we're big educators. So most of our work is done, speaking with patients or speaking with providers, collaboratively approaching as part of those teams to really work on what is the best for our patients, right? What treatments would work for them, and that is, team players and being part of the team is one of our biggest strengths, right? Is that collaborative approach, our communication skills, our active listening skills, and our desire to continue to learning. Because with pharmacy, it is a ever-changing world. Like every month we have 20 drugs coming out, new monoclonal antibodies, new classes of medications, new mechanisms of actions, and within same medication classes, there's new indications. So it's just a constant learning process. So constant learners. It's a big part of pharmacy.
Okay, and collaborative. I'm hearing that word collaboration.
Yes.
Detail oriented.
Yeah.
It's not only counting pills, right? It's much more than that.
We've evolved. Yes. But that's a piece of it, right? Because you need to have that dedication and that really looking at paying attention to details to make sure that your patients have the right medications, the right doses, that you're giving the right medication for the right indication, that the doses are correct. So there's a lot of math involved, right? You're doing a lot of calculations, especially if you have medications that are based on your weight, or you're looking at your patient's conditions or other things that could be interacting with the medication. So lots of adjustments, but we've moved a lot from counting pills to now really being part of prescribing those pills, right?
Awesome. So I mean, you talked about all the new medications, and obviously we have had a rash of medications, new medications, and in my world where I do a lot of weight loss and everything else, all the new weight loss medications. Is that just the sheer number of medications increasing year to year? Are the old medications going away, or how do you compound increasing, knowing all of these medications and all their mechanisms of actions and so forth?
Yeah, and that's a great question, because as we get medications, not necessarily are the new shinier ones better, right? So sometimes you have to really look at what's working for your patients, and some of our patients are for chronic conditions and are very well maintained on their medications. It's when medications either stop working or the patient progresses, where you're looking at or they have an adverse effect related to the medication, where you really now need to look for another strategy. I mean, most of the medications that are coming out now are really targeted gene therapy, monoclonal antibody types of. You talked about the weight reduction one. So there's all these new things, but there's also non-pharmaceutical, non-medication related things that we could treat our patients with that we try to do always first, right, before we go to medication. So, but old medications are still good, right? We used to use them all the time.
I've heard here so many times prevention is better.
Absolutely.
And everything from eating correctly, not smoking, getting plenty of sleep, all those things are much more
stress
important.
Reductions.
Stress reduction.
Stress is a big one.
Yeah. All right, so let's get into our topic, opioids. We're going to talk about opioids. Tell our audience, what are opioids?
So opioids are obviously medications we use to treat pain. And they work on various receptors, right, in the brain and the spinal cord, and they help to stop the propagation of pain or the pain sensation. And at the same time, they alter some of our receptors in our brain, so they cause some, they work on the pleasure part of our brain, so they cause some happiness to patients as they take these medications, which is sometimes where we run into our issues with opioids, where you can start to become addicted to these medications eventually. But they're basically used to treat pain, acute, pain that is acute or chronic pain that we see in patients.
Okay, so why? Obviously, the opioid epidemic is because of the addiction, I would imagine, right? It's another, just like alcohol or smoking or another type of drug. It's a drug. Why are we in this epidemic? I've heard stories about OxyContin being really one of the ones where really, kind of started this epidemic. Why are we in this problem of opioid epidemic?
I think it's multifactorial, right? I think when some of these medications first came out, like we have different types of opioids, right? We have ones that are natural opioids, and then we have things that are made in the lab, like semi-synthetic. So one of the first semi-synthetic opioids that came out was like OxyContin, right? Or one of the ones that are oxycodone, which is one of the ones we hear about. And, the marketing for those drugs were great when they first came out, right? So it was all about treating pain, and we have something new that's long-acting, and then you could start, using. And we tended to give these medications and overprescribing some of these medications, and maybe prescribing more than we should to some of our patients. And then eventually, over time, patients became addicted to them, saw the benefits of using these medications. And, at one point, an OxyContin pill was running through the black markets at about, $300 a pill. So there were physicians, back then that, didn't know the dangers of these medications. And over time, it just became something that patients felt better, and they started using this and using it in other forms as well.
All right, so we're on our way down, right? It peaked a couple of years ago, the opioid epidemic, right? So where are we today with this opioid epidemic?
So right now, there's a lot of programs that are out there looking at, how do we prevent opioid, and it's a lot of strategies for preventive techniques that we use or we employ, right? So we have, through various different programs, we've limited the amount of medications that are out there. We've created, stronger restrictions for ordering of these controlled substances or opioids in general. There's more physician, tracking. Pharmacists are able to, look through databases through our state or government, where we look to see prescribing patterns, where we're able to see if there's what we call shopping around of patients, where they're going to multiple different providers for prescriptions. So we're able to see. We've limited the amount of medication. So because of all these different strategies, and there's other various strategies that we've implemented throughout the states, you've seen less of it in the community, but then you've seen other types of medications surging, right? So things like fentanyl, which are synthetic medications laced with other types of opioids. But we've definitely seen more of a approach where we have now certain programs or things. For example, if you go into a hospital and you have an opioid overdose of any choice, or there's a suspicion, you're able to be discharged with Narcan. So we have Narcan programs, which is a medication that's used to reverse the effects of opioids or antagonize the effects. So again, there's many different things that are now using to prevent that. So we are seeing that downward slope. There's more awareness in our communities. So providers are more in tune to it. There's alternative therapies that we're giving to our patients outside of opioids for pains. Like we were talking about a little while ago, which is just non-medication, like things like alternative therapy, like sleeping better, right? Physical therapy for pain, using non-steroidal anti-inflammatory drugs, like over-the-counter medications like Tylenol. So there's alternative medications that we're trying to put out before we go to these stronger pain medications for our patients.
And so obviously those are for the patients that we're trying to prevent the opioid addiction to. So obviously right off the bat, I know for me, if I'm writing a prescription, I only can give them a couple days. Yeah. Now in the old days, for our audience to understand, I used to do a surgery and I would give them 30 pills of an opioid, right? And of course, patients would take 1 or 2 pills, and then they would be lying around, and then that would be an impetus for possible addiction or use by that family member or somebody else. Nowadays, you can only give them a couple days of pills, or 10 pills, or 8 pills, or something like that. What about those people that are already have the addiction and they're all involved in the opioids? What are we doing for those?
So depending on what stage you are, right? So there is some medications, there's what we call the opioid assistant therapy programs or alternative therapies, where there's other types of opioids that aren't as addictive that can be given to those patients. So there's there's medications out there. One of them is methadone, another one is buprenorphine. So depending on what stage you are in your addiction, that is one of the medications or strategies that we try with our patients, because you still have some of the opioid effects, but not the euphoric or the pleasure effect that you get in the brain. And just like you said, like limiting those medications, treatments, there is a lot of community programs to help with, Opioid Anonymous is one of them that you see, or, there's a help out there through the community, through counseling as well. But basically really trying to, make sure that they do have the tools in case they ever do, relapse or have, any adverse effects from the opioids where they can, harm themselves and die. So like things like the Narcan, right, and things as such. Our community itself and our rescue, rescues now carry Narcan. So that's one of the things that now we're training for, to make sure that when we see these patients or someone's at risk, that we are able to treat these patients sooner rather than later.
All right. So how does a family member identify somebody who may have an opioid addiction? Obviously, you've already very eloquently told us all the facilities and all the resources that are available in our community. So when should I be concerned if my family member is taking opioids?
Yeah, and that's the hard part, right? The socioeconomic piece of it, and the family involvement. Really, it's looking at different patterns, and if your family member was taking pen medications, right? Like how are they feeling? Are they drowsy? Are they overly sedated? Do they really need their medication? Like, are they acting differently? What are they? Are they having? Are they overly sedate, like drowsy? Are they tired all the time? Are they jittery? So things that you would see in somebody who's addicted, who's maybe going through withdrawals, right? And then when they have the medication, then are they feeling? How do they feel? Are they better? So I think observing them, what are they taking? What are their symptoms? How are they feeling? How a lot of patients that you see that are addicted to pain medications actually can't function. They can't drive. They can't. They start like not being able to go to work, missing days of work. So things that you're not seeing on a usual basis. So.
But they shouldn't be taking these opioids. Is there anybody that should be on these opioids on a long period of time? I mean, you just had recent surgery.
Yeah.
Okay. You had a broken leg or you had an accident. Okay. But should my family member be taking opioids, month after month?
So unless you have chronic conditions such as an oncology or some sort of cancer, like some that we see patients long term is for example patients with bone cancer, right, where they've already tried nonsteroidal and like for example acetaminophen or ibuprofen, and then eventually they'll go to long term chronic conditions that will require pain management. Patients who are end of life types of patients, where you'll see them at home on really stronger opioid-like medications to keep them outside of the hospital, right? But to keep them comfortable at home. But if your family member does not have any of those conditions, and you see, they should not be on these therapies more longer than 3 or 4 or 5 days, right? For any type of condition. So.
All right, and so you guys, as the pharmacists, where do you guys play the role in trying to prevent or impact this opioid epidemic?
Right. So really, it's at the point of when we get these prescriptions, right? So when we see out in the community, for example, coming into a pharmacy, when we look at these prescriptions, we're really looking at them. Are they really being used for the acute pain indication? How many are being prescribed? If you see 40 or 50, your counts, you're going to call and you're going to try to verify and talk to the provider and really have that collaborative communication and approach with the team and say, hey, what are you treating? I think you made, I think this is not the right amount, or this patient, could he use something else? This is pretty strong for a teeth extraction, right? Like, so dentists, that's one of the ones that at first, when the opioid epidemic was happening, you saw 40 OxyContin or Percocets from a dentist, really, for a tooth extraction. You only need like 1 or 2 days, right? So those are the types of things that the pharmacist would be looking at based on indication now, and that's one of the good things is through these different programs that we've implemented, we're able to see the indication for why they're using these pain meds, so we can question and have a conversation with the patients and really find out what the use is.
Now, something I've heard, and I've had this for patients, and clarified this for me. Patients call around to ask, I give them a Percocet prescription to go home with after surgery, and they call me back and they say, I've called 5 pharmacies, they don't have Percocet.
Yeah.
And I heard once from a pharmacist, that's because people are shopping for those medications, and over the phone, the pharmacist will always tell you no.
Right.
Is that true? Is that?
So I don't know how true that is, right? But I know that at one point early on in the opioid epidemic, that was the case, right? People would, patients would come in and have a prescription, and then if you didn't have it here, they would go to another pharmacy, or they would have 2 or 3 different prescriptions. As we've evolved through the era through this era, we're able to see what pharmacies you went to prior to coming to us and what was filled somewhere else through these different, assistant programs that we could go online and check. So now it's more transparent, but the truth is, like, pharmacies don't carry large quantities of these controlled 2 substances because of the regulatory compliance that keeping them, right, and the expiration. Like, so if you're not using these drugs, so sometimes for patients, the best thing to do is to go to possibly, something related, like a retail pharmacy with a hospital, like that has, for example, patients being discharged from surgery, or high levels, patient who had a cancer institution, right, where you may have patients who have more risk of having those types of opioid medications, because sometimes they just expire and then they don't keep them, or it's just that piece of it. The independent pharmacies, and they have, but it's just they may have other different types. And with a controlled 2 substance, like for example, Percocet or OxyContin that we were talking about, it has to be specific for those. Like once you write the prescription, it's specific for that type of medication, and that one we can't really substitute it. In the hospital we could for other agents, but outside you can't. So that's why it's sometimes it may be tough.
So it may be true. It may be
true. I wouldn't call. I'd go in person.
Go in person. Okay, that's a piece of advice. All right. Is there hope? Are we making? Well, obviously, we've made progress. What is the outlook of this opioid epidemic over the next 5-10 years? There's a lot of conversations about, that stuff is not even going through pharmacy. It's coming on the street. It's coming through the borders. It's like the new marijuana and cocaine, I guess, from the cocaine from the 80s. Is there hope for this opioid epidemic?
Yeah, there's hope for sure. Always hope. The more that we do programs like this and awareness to the community, where we're really sharing what to look out for, and how there's so many different things mixed with other medications out there, right? So before you go, somewhere else to get medications, really go through your pharmacy, go through your providers. The more education, the more the community knows through take back programs that we have, where medications aren't out there in the community, right? Where we're out there talking about the opioid epidemic and all the different things we have, having medications out there available, and Narcan, and just including, that part of education in our schools and in our families and the news, and just kind of sharing that information. Eventually our volumes are going to start decreasing, right? It's actually the number 1 death in the United States, right now.
100,000 people die from opioid. That is crazy.
It's a number to me that when I looked at it, it's wow. And every time you see it, but the number is decreasing, right? So there's hope out there, and as providers become more aware, and I think, as we tell, our kids, right, are going away to college, a lot of kids went away to college that I know this year. And that was one of the things we said is, hey, don't take anything out there, because there's a lot of things mixed with, for example, things that you use to help you study, and things like that, not to take those medications. Go through the proper channels. If you do need something, go see your doctor and get your prescriptions. Don't get anything through the black market, right? Because you don't know what anything is mixed for.
They're lacing all types of things.
All types of things. Like fentanyl is mixed in with things that you're smoking, like in the vapes, the vapors. There's so many different things that you hear from people.
Wow.
And young kids are, and I say young, but college kids are.
College kids, right?
Yeah.
They get pulled into that.
Yeah.
All right. Well, thank you. Thank you for everything you do with our patients at Baptist. And thank you for educating us today. And obviously, we've learned about the opioid epidemic, and obviously bring awareness to our community. If you're concerned, if you have a family member or a friend that you may be concerned that's taking these pain medications excessively, seek some help. Opioids Anonymous, and go online and get some help. And obviously, if you're interested in pharmacy and you're a collaborative individual interested in details, maybe pharmacy will be an area of interest for you. So thank you, Esty, for coming to join us. Thank you for educating us.
Thank you, Dr. Gonzalez, for inviting me.
All righty. And once again, Dr. Anthony Gonzalez from Miami Community Health. Thank you for participating with us today and being educated about the opioid epidemic. Take care of yourself and your family.